Hello, welcome to this update on obstructive sleep apnea screening guidance for aviation medical examiners. According to the federal air surgeon, the new guidance will significantly improve the safety of the national airspace system while simultaneously improving pilot health and career longevity. Today, I'll walk you through a triage function resulting in 6 possible determinations. But first, a little history on this topic. In 2008, the NTSB provided recommendations to the FAA to mitigate the safety risk of obstructive sleep apnea. In response to these recommendations, the FAA developed lectures on sleep-related disorders, and in particular, obstructive sleep apnea, to be delivered at all training events. Unfortunately, after 5 years of awareness training, the number of pilots identified with OSA was virtually unchanged. It's important to note that the NTSB has recently placed OSA on their most wanted list for transportation safety improvements for 2015. As a result, the FAA has developed new guidance to address this growing concern. This video outlines the process that AMEs are expected to perform at each pilot examination. The process is a result of input given by industry stakeholders and medical practice guidelines established by the American Academy of Sleep Medicine, or AASM. AMEs will perform what is essentially a triage function, screening and assigning pilots into one of 6 OSA groups while entering exam results into AMCS. We do not expect the AME to perform a sleep medicine evaluation, nor do we encourage it. When performing the triage, it is important to keep in mind 2 principles. Number 1, a pilot should not be denied or deferred unless the AME believes he or she represents an immediate safety hazard. This should be rare regarding OSA. And number 2, no pilot will be deferred based on body mass index alone. Let's go over how an AME will assign pilots to the OSA groups. When examining pilots for OSA, AMEs should apply clinical judgment using criteria developed by the AASM. Risk assessment is determined through evaluation of history, symptoms, and physical findings, including questions about OSA that should be part of a routine health maintenance evaluation according to the AASM. Pilots determined to be at risk for OSA will be issued a medical certificate and referred for an evaluation. This evaluation will not require a laboratory sleep study or even a home study if the evaluating physician determines it is not required. Included in the new guidance is a decision tool that will guide you through the 6 possible determinations. Let's look at each of the 6 groups individually. Group 1 is for those pilots who have already been diagnosed and are currently on an AME-assisted special issuance. Group 2 is for pilots who have had a sleep evaluation but did not report the findings, regardless if found positive or negative for a sleep disorder. The AME must give the pilot a copy of Specification Sheet A, which outlines the information the pilot will need to provide to the FAA. An official request from the federal air surgeon will follow by mail. The pilot will have 90 days to comply, but may request an additional 30 days if needed. Group 3 is for those pilots who do not have any risk factors of OSA as outlined by the AASM. No further reporting or evaluations are needed. Group 4 is for pilots who may meet some criteria for OSA but do not have any clinical signs or symptoms. The AME is encouraged to provide the pilots with FAA educational material and suggests the pilots follow up with their personal physician. Group 5 is for pilots who have overt signs and symptoms of OSA and will need an evaluation. The AME must give the pilot a copy of Specification Sheet B. An official request from the Federal Air Surgeon will follow by mail. The pilot will have 90 days to comply, but may request an additional 30 days if needed. Group 6 is where the AME determines that the pilot's risk for OSA is significantly high and is an immediate risk to aviation safety. We expect this to be extremely rare. For example, the AME enters the exam room and finds a pilot sleeping and witnesses prolonged apneas. In these cases, pilots should be deferred. Note that deferral only applies to Group 6. In summary, the result of your clinical decision-making using FAA OSA guidance will correlate directly to the AMCS notation you make at the conclusion of the examination. Today, we've covered OSA screening guidance, the 6 OSA groups, and documentation requirements in AMCS. Our goal was to make this OSA screen and detect process standards-based and straightforward for our aviation medical examiners. Going forward, keep these 2 guiding principles in mind. No pilot will be deferred or denied unless there is an immediate safety hazard, and no pilots will be deferred based on body mass index alone. For more information and additional reference material, refer to the new section in the Guide for Aviation Medical Examiners at the link provided. Thanks for watching. We appreciate the job you do keeping our skies safe. See you next time.